How do you choose which patients would be appropriate for immunotherapy?
So right now in the second-line setting, we have two approved options. Okay, one is regorafenib, based on the RESOURCE trial, and the other one is nivolumab, which is the Checkpoint 040 trial, which we're talking about now. And there's not any one right predictor of response. There's no markers that suggest one treatment or the other would be more active. You need to look at the patient's underlying comorbidity risk and risk for toxicities when you make those decisions. Significant underlying liver dysfunction may be better to start with a checkpoint inhibitor, since regorafenib is known to occasionally cause significant liver dysfunction.
Can you comment about the use of immunotherapies in patients that potentially have autoimmune problems already, or maybe patients that are going to go on to a liver transplant or have already had a liver transplant?
This is a very hot area of debate and I'm sure research interest. And the two points you brought up, one are related to patients with underlying autoimmune disease, and the second one is patients that are going to be transplanted or have been transplanted. And so there's no data. The studies that use checkpoint inhibitors excluded patients with autoimmune disorders, and this is something that should only be used very, very selectively, if at all. In terms of transplant candidates or patients with transplant, again, it probably should be avoided at this point in time because the immune milieu of the liver is complicated, and there are case reports in other organs transplant settings where immune checkpoint inhibitors have led to graft failure.
I think this is a very important thing to think about when we're talking about the different options for our patients.